delighted to introduce our next speaker, Dr. Glenn Treisman. He is the Eugene, you can see that there, the Eugene Meyer Professor of Psychiatry and Medicine, and numerous accomplishments here at Johns Hopkins in the field of psychiatry and in areas, some specific areas to include HIV disease and pain treatment. And he's known as the author of The Psychiatry of AIDS. That's the first comprehensive textbook of the subject. And among his awards includes receiving the William C. Menninger Memorial Award for Distinguished Contribution to the Society of Mental Health, given by the American College of Physicians. So please join me in welcoming Dr. Treisman. Thank you.
Thank you very much. Well, I apologize to you. Adam Kaplan was supposed to give this lecture, and he's in Amsterdam, so he's not giving it. So you're stuck with me. We treat a lot of depression here at Johns Hopkins because it is an issue that affects all care of all patients. Depression is the most common psychiatric disease. Roughly 4% of the population suffer from it. And what we've observed over the years is there's a huge press right now to try to identify everything as being one thing. Depression is not one thing. Depression is a lot of things that converge on one condition. And there's genetic influences, and there's personal influences. And one of the things we're very interested in is inflammation and lipid metabolism and depression. And people knew about that 100 years ago, and probably 1,000 years ago. But there's some nice research I'm going to show you today. We treat refractory depression a lot at Johns Hopkins, one of the things I'm an expert at, and many of us are experts at. And so exercise has turned out to be an incredibly useful treatment for us. Exercise has been shown, now I'm going to show you some of the studies, to be very effective as an adjunctive treatment for depression. But there's a bunch of problems. I'm going to take you through some of the problems today in terms of thinking about not just what I do, but what we all do and how we know what we do works. So I have no conflicts of interest for this lecture, and I'm not a crook, said Richard Nixon. I'm going to talk to you about the problems of trials with antidepressants in general. I'm going to talk about why depression is important to all of you. I'm going to talk about evidence for exercise as a treatment. So this is a little cartoon I have of depression causing a variety of things that make physical illness worse, and then physical illness causing a variety of things that have been shown to make depression worse. So if you get depressed, you're more likely to get physically ill. If you're physically ill, you're more likely to get depressed. Now, in HIV, this is particularly true. In fact, in any viral infection, but in autoimmune disease, this is true. Rheumatological diseases cause depression. Worsening depression will cause a flare of your rheumatological disease. And so this loop is operative in all kinds of things. And here's a series of studies that show both increased morbidity with all these conditions, but also increased mortality. If you have an MI, you're twice as likely to die if you have depression if you don't. And so all these conditions are dramatically worsened by major depression. And the question for all of us is, does the arrow go both ways? Does it go one way? And how do we understand these things? So if you have an MI and get depressed, do you have a worse mortality because you don't take treatment? Do you have a worse mortality because you're not exercising? Do you have a worse mortality because you're just sad, because your immune system dysfunctions? Or did you have an MI because you have chronic inflammation, and chronic inflammation causes both MIs and depression, and therefore you had a risk, and the worse your inflammation was, the more likely you are to have both? We don't know the answer to those questions. We're working on it. So there's all these meta-analytic methods in our field, but they're troubled by a number of things. One is, how do you tell when someone's depressed? Because you can be depressed and not have major depression, and you can have major depression and not be the least bit depressed. So I'm going to try to tell you today what depression is and why it's problematic. But if you decide someone's depressed based on a piece of paper checklist, the average person will make criteria for depression if they have it, but people with the wings of the curve won't. People who are symptom minimizers won't look like they have major depression, even though they do, and people who have symptoms of every imaginable sort who amplify their symptoms will look like they have depression when they don't. So these checklists are not very good, and if we're just talking about, we say depression, we're talking about the symptom severity of depression. If your mother dies, you're very depressed. But it doesn't mean you have major depression. You can have demoralization. So I'll talk a little about that. And then there's clinical diagnosis, which is the one that's most valid. That is, if you can get two doctors to agree that you have major depression, that's got the best validity in terms of what we do. But that's not what we do in any of the trials. When we did it, the trials were much more effective than they are now. Depressed patients in trials have poor adherence to anything you do for them. So they're not likely to take the placebo or the drug or do the exercise or go to the groups or go to the therapy, because depression makes you not do those things. In fact, depressed people don't come to see their doctor because they're depressed. And so it's hard to do a study of depression because the patients tend not to adhere. Depressed patients drop out. If you don't have depression, you tend to stay in the trial. If you're depressed, you tend to drop out of the trial. And the interventions are quite variable. What one person says is an exercise regimen or a group therapy session, very different than what another person says. So is group therapy effective for depression? Well, it depends on the definition of group therapy as much as the definition of depression. And then adherence is difficult to assess. How do you know the person did the exercise? Do you watch them do the exercise? If they do the exercise, are they really doing it, or are they just kind of? And so these things confound some of the data I'm going to show you today about both antidepressants and exercise. So this is a study that was published in 2008 in PLS Medicine, and it got a huge response. This guy, Kirsch, thought that antidepressant trials are all tainted by the drug companies, and therefore he meta-analyzed all the antidepressant trials, and he showed that now if you meta-analyze them all, they're not much different than placebo. In fact, they're not different than placebo until you get really severe depression. And his conclusion from this study was there's something wrong with the drugs, and they don't work. My conclusion was this: there's something wrong with the trials, and there's something wrong with the way they were meta-analyzed. Now, luckily, since this, several meta-analyses have shown that antidepressants do work, bring a big relief to the patients who are better on the medicines. But this study really provoked a lot of people to say maybe antidepressants don't work. Even patients who were well on their antidepressants came to me and said, hey, this medicine you give me doesn't work. I said, you're better. You're working. Your wife is no longer divorcing you. You can go to the gym. You can think. How do you know it's not a placebo response? I gave you 6 medicines. It was number 6 that worked. Numbers 1 through 5 were perfectly good placebos. But the conviction people have that we in medicine are all full of stuff, and especially in psychiatry, is profound. And so you have to have data to back you up when you ask patients to do things. Now, this is a study that was done many years ago called the ECA study, and it showed that the prevalence of depression is about 4%. That's been the prevalence of depression since the beginning of time. Anybody who studied it always finds that. But the National Comorbidity said it's 16%. So did it increase fourfold in 20 years? No. How we assess depression changed. These people have major depression. These people are depressed. And that's a big difference. And in fact, there's 2 kinds of depression. There's the kind that's a disease of the brain, and the kind everybody in this room has had when something goes wrong. This kind of depression I'll call demoralization. Understandable psychological response to loss that every one of you has. So your mother dies, you're going to be depressed. You wake up one morning, you're the aide psychiatrist at Johns Hopkins, you can get depressed. And this condition responds really well to psychotherapy, encouragement, time, and support. It doesn't respond well to antidepressants. By the way, it probably provokes inflammation in some people. Makes your inflammatory status worse. You will have flare of their Crohn's or flares of their rheumatoid arthritis when they get demoralized. This kind of depression, in your brain there's a circuit called the ascending mesolimbic dopamine circuit. It's the yeah circuit. You all have one of these, and when you get something really good for lunch, if you're hungry, when you eat it, you get a little yeah. And that chemical is dopamine. And people with depression are desensitized to dopamine. Instead of getting a yeah, they get a eh. Shoot a 30-footer, eh. Get a grant, eh. That kind of depression, some people will do more. Most of you will do more. If you get depressed, you work harder because you're trying to get your yeah, right? Trying to get, like, maybe if I get a yeah, if I get 2 grants. And other people do less. They're depressed. They don't get out of bed. They take to bed. It's the old description of depression. So this condition is really a condition of reward, of loss of GABA or dopamine in response to stimuli. And this responds very well to medication. The problem is these things look very much alike. They're hard to tell apart. These people tend to be distractible from their loss, so they'll be cheerful for an hour, and then they'll be remember why they're sad, cheerful. Usually have trouble falling asleep. Once they're asleep, okay. These don't go with family history. Each episode is unique. The person tends to have a stable life course, and the person tends to respond to positive events. These people have profound anhedonia. They lose that from things. They have AM insomnia. They wake up early in the morning, can't fall back asleep. Usually family history, similar episodes, a disruptive life course, and unresponsive to positive effects. But you see they overlap. You can have both, and sometimes you can't tell which is which. If you're doing a study and you lump these people together, you get this. So how do we put people in a study now? They fill out a piece of paper, and if they make criteria on that piece of paper, they're in the study. And the paper doesn't distinguish between these two things very well. So this is all the trials done between 1980 and 2000 for tricyclics and SSRIs versus placebo. And between 1980 and 2000, the placebo response goes from 20 to 40%, and the drug response goes from 40 to 60%. That's because more and more we're moving away from academic centers and away from clinical diagnosis and more to checklist diagnosis. And the drugs still work as well as they ever did. But the overlap here is larger because the error bars are larger because some of the people in the trial don't have the condition. And that's a problem with exercise studies as well. Are we talking about major depression, or are we talking about I'm depressed? People who are I'm depressed are different than people who have major depression. So this is a critical review, and it basically says all those things I just told you about depression, about exercise studies. It's difficult to get the patients to do it. For every person who was in the trial, for every person who got in the trial, 10 patients had to be screened. The patients in the assigned arm didn't do what they were supposed to do. The expectation signing up for an exercise study, the control group didn't want to get the medicine. They wanted to get the exercise group. There was no blind. You're doing exercise versus medicine or exercise versus psychotherapy. You know what you're doing. I can't give you a sugar pill and a real pill. I have to give you exercise or a pill. So these studies are not blind, and patients don't want to engage in the treatment. And then there's a lot of heterogeneity in interventions. Were they supervised or non-supervised? Did they get aerobic versus anaerobic exercise? How long? What type of exercise? Is it real life exercise or virtual reality exercise? And then do people exercise by themselves or in a group? Because a group itself is a powerful salutary effect on depression. So now you want to know, does exercise help? And I'll tell you it does. So this is a study of 23 randomized controls in 977 patients, meta-analyzed, and exercise had a significant effect. No intervention had a much larger effect. So exercise had a good effect, and when you compare it to psychological treatments, it's probably not much better, but that means it's as good as other kinds of treatment. So it's not better than medicine, but it's as good as medicine. It's not better than psychotherapy, but it's as good as psychotherapy. When you add it as an adjunct antidepressant, there's a moderate effect that leans towards significance in this study and other studies. It's been very powerful. So again, it depends on selection bias. So I think it's an adjunctive treatment. And again, it depends on the medicine. So in clinical practice, I often give people certain kinds of nutritional supplements for depression. Acetylmethionine and levomethylfolate are good, but not if you don't exercise. They're useless. I can't show you data to support that. I can just tell you that in my experience, if the person is going to exercise, those things don't work. If the person exercises, they really do help. So a lot depends on how you study. This is that same study, just showing you the effect sizes across the board, basically showing that antidepressants help, psychotherapy helps, exercise helps. Put them together, you get more. This is another meta-analysis. In this study, we're looking at 35 trials with almost 2,500 patients. And again, in this study, exercise works. Here's again this long series of studies, and you can see that we've got good effect from our exercise. And so This study studied both exercise as a treatment, but also they reviewed exercise as a prophylaxis against relapse. So when you get people better from depression, a lot of them get sick again. Turns out that one of the ways you can be guaranteed to get sick is take not enough antidepressant. So in my day, antidepressant doses were much higher than what people are using now. The reason for that is when you do a trial, you're a drug, you want to use the lowest dose you possibly can. So you have the fewest side effects to report that you possibly can. And you only have to get people better than placebo at 8 to 10 weeks. So use a little tiny dose, people get better, they don't stay better, but you're only doing the trial for 8 to 10 weeks. And they don't have to get well, they just have to get better. And that way you can report the least side effects. And so all the trials use doses of antidepressants that are way too low. Duloxetine, Cymbalta, for instance, use 60 milligrams. Well, in clinical practice, I give everybody 120 milligrams. That's the thing that will get you all the way well and keep you well. But the PDR recommends 60 milligrams because that's the trial dose. The problem is nobody did a trial for 2 years. In HIV, the world I come from, if you want to get an HIV drug target, people have to be virally undetectable for 2 years. People give big doses of those medicines so that they won't have any breakthroughs, so they won't lose their drug. But in the antidepressant, all you have to do is placebo at 10 weeks. So the trial standard is different, and so doses are wrong. And so people tend to underdose antidepressant medicine. So you can see people relapse at very high rates. And in these studies, what they looked at was how likely are you to relapse. And since a lot of people relapse, it was kind of easy to show that depression helped prophylax people relapsing. In fact, exercise is both good for treatment depression and prevention of depression. Exercise intervention decreases the severity of depression, decreases the risk of relapse. It decreased anxiety, pain, fatigue, insomnia, and hostility. It improved cognition. It improved physical health. And the effect size when using conjunction with other treatments increases. So you get better effect with exercise plus an antidepressant, exercise plus psychotherapy. We have a bunch of biomarkers that are candidates for looking at this, particularly brain-derived neurotropic factor and oxidative stress and chronic inflammation. Chronic inflammation will give you depression. Depressed people have more chronic inflammation. So there's both candidate transmitters and candidate conditions that exercise helps that would mean exercise would be helpful for depression. This is an elaborate study looking at people at the VA Medical Center with a path analysis for exercise and its influence on depression, PTSD, sleep, all of which influence suicide. This is a direct decrease of 18% in suicide. There's an indirect decrease in depression, which means a direct 19% decrease, 0.19 I should say, sorry, and 0.15 decrease in suicide if you're sleeping well, and exercise helps sleep. And so, and this is suicide by gun, suicidal ideas, and suicide attempts. So what you can see is that these things all influence each other. So exercise is a profound influence in this study on outcome. Suicide is not depression. Suicide is a behavior produced by depression. That means that this is a very practical study. Not only are people less depressed, they kill themselves less. And ultimately, what you want to know with depression is the person's function changed? So when you treat depression, you not only want to treat depression well enough that people feel good, you want to treat depression well enough so people function well. And so this study showed that they do. And can exercise prevent depression? This is a different set of studies, but in a healthy cohort of 33,000 adults, essentially, depression improves your likelihood or decreases your likelihood of getting depressed. So if you exercise, you're less likely to develop depression. And again, there are parallel studies that show that exercise decreases inflammation, decreases certain short-chain fatty acids that you don't want, decreases other lipids that influence health, and decreases cardiovascular risk. So we know that we're decreasing inflammation with exercise, but we also show decreased depression. So does stopping exercise make you depressed? Now, one of the problems with this is, did people stop the exercise because they got depressed? Or did people get depressed because they stopped exercising? I can't tell you the answer. I can tell you this. Every patient comes to me and says, my boyfriend broke up because I got depressed. so I was depressed. And they always think that it was they got depressed because the boyfriend broke up. But what really happened is the boyfriend broke up with them because they were depressed. That's what makes people break up with you. Relationships with depressed people become very unstable. So understanding that people always give a life story explanation. People with really bad depression with hallucinations say, well, it's because this happened at work or because this happened to this person. You're supposed to come up with an explanation. They're not always right. So you have to know which comes first, and we don't. You know that people with chronic pain are more likely to be depressed. You know that people with depression are more likely to have chronic pain. In the large ECA study, at time point 1, if you were depressed, at time point 2, you were much more likely to have chronic pain. But if at time point 1, you had chronic pain, at time point 2, you were no more depressed in that study. So it's not always as simple as the patient's explanation. However, having said that, in 7 databases that they searched, in this large group of patients, stopping exercise increases depression as little as 3 days. And it gets worse to up to 14 days. And female participants had more symptoms than male participants, and depression in general is more common than men, although that may be ascertained. So the take-home message is, if you're exercising and you're not getting depressed, you stop exercising like you get depressed. Exercise treats depression. We want you to treat depression. This is physical exercise for late life depression. As all of you know, we're very concerned about in elderly people this measure of frailty. You can become frail. And it turns out that if people exercise, it decreases their frailty. And we think there's an association between depression and frailty. And we think it probably has to do also with some of the same transmitters that are present in inflammation. But basically in this study, they showed that if you exercise in elderly patients, they get better faster, and they outdo just general people. So physical exercise is good for depression in general. It's good at late life depression. It's probably better at late life depression, and it's important. Then the question is, how much exercise do you need? If you're over 30, some exercise for depression is clearly better than no exercise. If you're under 30, there may be a threshold effect. So for young people, it may be necessary to actually exercise to a physical limitation. We don't know what that is. 3 times a week for an hour is usually about as the number for the threshold. So if you're in the military, for instance, you heard about the military. We believe that people in the military are actually less likely to get depressed if they are in physical training, because they do at least 3 hours of hard exercise. Looks like that protects them. How does it work? I already told you that there are specific brain regions that you can show work better and get bigger and change with depression. I won't drag you through it. They're all the areas of the brain that are involved in depression. And they change in volume as you get this. So you were taught in elementary school, neurons don't divide when you're an adult. That's true in general, but it's not true in specific. There are certain brain areas where neurons continue to divide. When you get depressed, they stop. When you get better, they start dividing. And so those areas will swell a little bit, shrink a little bit if you're depressed. And so you can show some of that change with people exercising. And then clearly, exercise is an anti-inflammatory treatment. And and then stress axis, the HPA axis, cortisol levels go up with intensive exercise, which sort of desensitizes you to cortisol that's there at the time. Instead of having chronic stress, you exercise, cortisol goes down. So all these things are mechanisms that have been proposed as why exercise helps depression. And if you're physically inactive, we can show that all of these things, digestive changes, reproductive changes, nervous changes, physical changes like sarcopenia and disuse atrophy, heart disease, and related problems, insulin resistance and metabolic syndrome, bone changes, and rheumatoid arthritis are made worse by physical activity. And all of these affect depression. So there's a lot of routes to depression. And so basically, it looks to me like exercise helps at a variety of places and is incredibly important in getting our patients better. Now, this is, I think, the dosage needs adjusting. I'm not nearly as happy as people as. We live in a kind of condom Coca-Cola society, where what people want are quick and easy fixes. Being depressed is not the same as being unhappy. A lot of patients come to see me and they say, I'm depressed, meaning you're not happy all the time. You're not supposed to be happy all the time. You're supposed to work toward happiness. We're guaranteed the pursuit of happiness. We're not guaranteed happiness. And pursuing happiness means you have to do something. To get happiness, you have to do something. Exercise is a thing you do. You develop fitness. Were it not good for major depression, it's still psychologically good to do activities that are productive because they produce happiness. They don't just treat depression, they produce a more satisfied person. There are lots of studies that show that. Unfortunately, what people want from me is a pill that they can take so they'll get promoted at work, make more money, have more sex, look better, feel better, wear better clothes, have better sales on Amazon, and essentially be happy all the time. None of the pills we give for depression improve happiness. They improve dopaminergic transmission function. You have to get the happiness yourself. And one of the things doctors have to know is how to distinguish between people who think that they should feel a certain way all the time and are trying to feel a certain way all the time, between people and between those people who are working to get better. Because the people who are working to get better, you're going to be able to treat them very easily. The people who think they should just be better by magic, they're going to be tough. And they need the kind of psychotherapy that experts can provide, try to get them on track and get them exercising other things. So the all-in-all preponderance of evidence supports the role for exercise in the treatment of augmentation, and future research will elucidate how to get people to exercise, personalized strategy. And you have to remember, each person is different. So although everybody needs treatment, the treatment isn't the same for everybody. And unfortunately, what people want nowadays is a little algorithm to follow. And everybody's different. Some people exercise is going to work. Some people exercise isn't going to work. You have to think critically about what you're going to do for a person and fit what they're going to ask them to do into the kind of person they are and the kind of life they have. So it's incredibly important to understand that personalized medicine means knowing the person, not their genes. Anyway, I'll stop. Thank you guys for inviting me. I hope this is useful. Questions? Yes, ma'am. There are a couple of studies for exercise in bipolar. They're not nearly as far along as what's in depression. They are out there, but they're not ready for prime time. On the other hand, I tell patients you should exercise if they have bipolar disorder. One of the things that goes wrong with bipolar disorder is this dramatic increase in risk of cardiac death because bipolar patients tend to be on medicines that make them more inert, raise their lipids, and getting them to exercise will offset that. So you want to decrease the premature cardiac death of people with bipolar disorder. Getting them to exercise is good for that, even if it isn't incontrovertibly demonstrated to be helpful for the mood disorder itself. Yes, ma'am.
So I have a friend who actually fights depression, and lately no medicine has helped her. How did you come about trying to get her to maybe exercise more, or just kind of give her that push to maybe even try? Because she won't even try exercise.
Yeah. Well, I just tell people about the evidence, and then I try and get somebody that they know who exercises to drag to it. Same way I get people to go to group. When you're in the hospital, you don't feel like going to group. And I may say patients have to go to group, and they say, group doesn't help me. I say, I get to decide what will help you while you're here, not you. You have to go to group. You don't have to like group. You just have to go. And I push them to go. And then they say to me later, group really is helpful. I say, yeah, I'm so happy. I don't really care if it helps. I care if you go. People don't have to want to exercise. It turns out exercise is just as good if you hate it as if you love it. And so people are more likely to go if they go with somebody. People are more likely to go if you pay attention when they go and ignore them when they don't. And people are more likely to go if when they go exercise, they get a reward for the exercise. So I encourage people to set up behavior plans to get people to exercise. I have a kid right now I'm treating, and his parents have set it up so that he exercises. And he exercises every day. He's incredibly reliable because they pay him to. They don't pay him a lot, but they pay him to exercise. If he doesn't exercise, that's okay. He doesn't get any money. This turns out to work really well. I'm in a work for paycheck program of my own here at Johns Hopkins. If I didn't work, eventually I wouldn't get paid. That's how life is. So you can set up in programs that will help people do these things, and even in adults, with their permission, you can say, if you do this, you get this every. My wife says, if you do these things, I'll do this for you. And I say, great, let me at it. And turns out it's very effective. So we all live in a world of incentives, punishments, and rewards. And for people who won't exercise, you can make it appealing to them to exercise just by what comes from the exercise. And they get better. So, okay, thanks again for inviting me.
Thank you very much.
And,
It's wonderful. That was a great talk.